Welcome to our online session on time to act against sepsis, infection prevention for sepsis survival, organized by Voice of Healthcare and powered by Thermo Fisher Scientific. Sepsis is a severe, life-threatening condition triggered by infection. Timely recognition, infection prevention, monitoring, and early treatment is vital for survival. I'm Dr. Manisha Khurana, and on behalf of Voice of Healthcare, I'm delighted to host this session on this crucial topic. Our panelists for today's discussion are Dr. Kamini Walia, Scientist GM Head, Indian Council of Medical Research, ICMR, Government of India. Welcome, Dr. Kamini. Dr. Yatin Mehta, Chairman, Critical Care, Medanta, the Medicity, Gurugram. Welcome, Dr. Yatin. Dr. R. Subramanian V, co-founder, Director of Medical Services, Capstone Multi-Speciality Clinic, Senior Consultant, Infectious Disease, Apollo Hospitals, Chennai. Welcome, Dr. Ramasubramanian. Dr. Subhash Kumar Todi, Director, Critical Care and Emergency Medicine, AMRI Hospital, Kolkata. Welcome, Dr. Subhash.
Thank you.
Dr. K. Madan Gopal, Advisor and Head, National Health Systems Resource Center, Ministry of Health and Family Welfare, Government of India. Welcome, Dr. Madan. So to begin with, my first question is to Dr. Yatin. So what is sepsis and why is early detection crucial for patient outcome?
See, for the common people, sepsis is basically a dysregulated host response, which is life-threatening and can lead because of sepsis. In crude terms, that basically means that there is a site of serious infection in the body, which spreads to other organs, and your organ function, that means the kidney, the brain, the liver, the intestines, all can get affected. And you can, if you're not treated, diagnosis is not made in time and not treated in timely fashion, it can lead to death. So tomorrow is World Sepsis Day, and that is why I think we are talking about this.
Right. So, Dr. R. Subramaniam, what are the advantages of using procalcitonin over other diagnostic markers in sepsis?
The most important part of treating sepsis is that you diagnose the sepsis early, because it has been very clearly shown that anybody with sepsis who has probably a severe manifestation in the form of a hypotension or septic shock has a very poor outcome. So the sooner you detect, diagnose, and initiate the appropriate treatment, the better the patient outcomes are. So which means we are looking for ways, even though the blood culture are the gold standard in diagnosing sepsis right now, the reports take almost 48 to 72 hours. And even then, less than 20% of people have a positive blood culture, which means we are significantly challenged by early diagnostic modalities in identifying sepsis. Forget confirming sepsis, but even identifying sepsis. Over the last several decades, we have looked at various markers, including, apart from clinical features, a high white cell count, a high erythrocyte sedimentation rate, and a high C-reactive protein. Now, procalcitonin, which is a biomarker which has been shown to have a stronger sensitivity towards the diagnosis of sepsis. So serial monitoring of the procalcitonin is a very useful adjunct. I'm repeating, it's an adjunct. It doesn't confirm sepsis, but it definitely points the right way in looking at the trend towards the high PCT or a rising PCT in diagnosing sepsis early, so that we can initiate treatment early.
Very well said. So my next question is to Dr. Subhash, that how has the integration of PCT testing impacted clinical decision making in your practice?
I think there are two conditions where I've been using procalcitonin. One is de-escalation, or rather stopping the duration of antibiotic. If procalcitonin has come down by 80% or it is less than zero point 0.5, and then it's time that we can stop the antibiotic. But this has not been studied extensively in multi-drug resistant infection. Most of the studies in PCT on stopping antibiotic and decreasing the duration are on sensitive bacteria. So I think this is one of the field for research. can PCT help us in also stopping antibiotic if the infection is due to drug resistance? So that is one area which is very clear, at least in sensitive bugs, you can stop antibiotic with decreasing Procal. The other time I've been using Procal is in patient who have been in ICU and who have developed a secondary sepsis, and I'm not sure whether it is a fungemia or whether it is a bacteremia, and people end up having very broad spectrum antibiotic and antifungal, and because cultures are many a times negative there, if the Procal is very low, then the chance of fungemia becomes higher. Then you lean towards giving more of an antifungal. On the other hand, if the Procal is very high, then probably it's bacteremia. So a combination of low Procal and a high beta D gluten is very suggestive of a fungemia. Over to you.
Right. So, Dr. K. Madan Gopal, what roles do policy and funding play in advancing sepsis research, and what improvements are needed in this area? So, please unmute yourself.
Uh, Manisha ji, sorry for this.
Yeah.
Uh, this is one of the important and very pertinent question. What kind of quality things are required for uh, preventing sepsis? As rightly pointed out, that the identification, the early diagnosis of sepsis is one of the important things. And for identifying the early diagnosis, you require some standards, minimum things required in the hospitals and other things. In the public health institutions, we grapple with the issue because the perception of the people who are handling the patient that needs to change. Because one way, the perception is that we are having antibiotics. Why you are worried about the small nitty-gritty of uh, having a sanitized things when you are having a full cover? That kind of practice is also there in many of the public institutions. Having said this, there are many things which are to be done. We do have Indian public health standards which talk about the minimum essential things for the public health institutions. If you talk about the quality of services, then we have enforced standards from the ministry side, national quality assurance standards for the public health institutions. Similarly, for the private side, you are having the NA-based standards. So, so these are standards which are available. They are basically from the patient safety point of view. And the patient safety means how you prevent the asepsis and other conditions in the hospitals. But nevertheless, when the things are in place, we do have some other interventions also in place. So you just start with the Swachh Bharat Abhiyan, wherein the importance of hand hygiene and sanitation has been emphasized, overemphasized. Then the cleanliness of the institutions which are also there, the Kaya Kalp, that means it talks about the cleanliness of the public health institutions. And nevertheless, in the private sector also, you might have seen now how much importance is given to the cleanliness. The moment you enter the hospital, they say that yes, you have to stop. You have to either change your footwear or you have to change your dress and other thing before you enter into some of the critical areas. So that people stop, pause for a while, and then they are made aware that okay, this is required for maintaining this. The previously the zoning concept was not there. Now the zoning concept in the hospitals is coming. But nevertheless, Kamini ji is there. She will be more talking about the stewardship program for the antimicrobial resistance and other things. But we do have an infection control program from the ministry side. Ministry has released the guidelines, national guidelines are there. We're trying to see that how these guidelines are being implemented. Now, beside that, the main focus is see that how early diagnosis of sepsis happens and the use of rational use of antibiotics happen. These are the two focus areas which currently we are focusing on from the institution's perspective. Beside that, the major outreach things which we are doing, where we try to see that how the asepsis conditions are maintained so that sepsis doesn't happen. If you have seen the immunization program, if you see the sepsis following the immunization, that's not there. That's an indicator saying that how much focus is being made on sterilization as well as the aseptic condition under which the immunization happens. But once it comes to the institutions, the ICUs, the patient who is landing, even the best of the health institutions in the country, they usually have a central line infection. That's a marker, and we have to see that if a central line infection happens, that means something is missing. So we have to start right from the basics to see that how the advanced things can also be taken care. So standards are there. If you talk about the IPHS 22, it has given in nitty-gritty details conditions for what would be required in ICU, what is there for the SDU, what is the required for the OT complex, what is the things are required in the OPD setting, in the OPD settings, IPD setting, the ward also, everything is given. But the only thing is creating awareness among the providers and the implementers see that these are important things to happen. And nevertheless, the other challenge is to see that the other support staff which are handling it, they are also being made aware about the sepsis and other things. So work is in progress, and we see that how we tackle the epidemic of this sepsis because of the hidden epidemic, and nobody talks about that. They say that we can load the patient with antibiotics and that can be taken. But if the load of infection is very high, and most of the cases which die in the hospital is because of septicemia leading to multiple organ failures and the other catastrophe which has happened. So a lot of work is to be done, but standards are in place. The institutions are being made to work towards ensuring that sepsis and the other things, hospital infection control committees are also there. A lot of work is happening, but nevertheless, this is the point of concern, and we see that how we take the things forward. Thank you.
Correct. Correct. So I believe that prevention is the key. Correct. So my next question is to Dr. Kamini. What initially drew you to focus your research on sepsis and its biomarkers, and how has the landscape of sepsis research evolved over the years? And what are the key milestones achieved?
Thank you. Thank you for inviting me to this discussion, very interesting discussion and very timely, as well as for the question. So as you all know, ICMR has been undertaking the AMR surveillance for last 10 years. Our recent report was released last week. And the report shows the high incidence of infection of drug-resistant infections in the hospitals which are part of AMR surveillance network. Now, these are all tertiary care hospitals who receive patients who have been previously treated, who are referred to these hospitals. So all the data which is actually presented from these hospitals essentially doesn't reflect how the patients are treated in these hospitals, but how the patients are treated in generally, and how they land up in the tertiary care hospitals with these drug-resistant infections, and these tertiary care hospitals subsequently have to deal with these very sick patients. Most of the time, what we see is that they are at an early stages of onset of sepsis when they reach these hospitals. So this actually drew us to a point to understand what is the diagnostics which are currently available in the country that can facilitate early diagnosis. Since the management of sepsis will happen at three stages: the prevention, the diagnosis, and the treatment. Prevention, the previous speaker has already alluded to and described very nicely that we have to avoid infection, whether it is in community or whether they are hospital-acquired infections. So what can we really do to improve the diagnosis so that there is early diagnosis and there is prevention of mortality associated? Because what we have found in the ICMR study, which is currently ongoing, is that we have almost 28% mortality in the sepsis patients who are in the ICUs of the tertiary care hospitals. So we need to prevent that, and to prevent that, we need to diagnose early. And what we realized was through one of our projects that all the diagnostics which are available in the market, mainly it is the gold standard is blood culture. There are few other diagnostics which are available, which give us result in a shorter time, but they are very, very expensive. So we need a affordable diagnostic which can guide us to early detection of sepsis. So that led us to development of target product profile for sepsis diagnostics, which can then be used by any innovators who are currently engaged in development of new diagnostics. And believe me, it is a very fertile scenario right now. Many innovators and many new the researchers are actually engaged in developing new diagnostics. So we would like to have a three-tiered diagnostic. We need one which can help us with screening at an early stage. We have also proposed that we need a diagnostic which can help us in pathogen identification, and we need one which can actually help us in the antimicrobial susceptibility testing. So globally also there is a lot of discussion. Recently there was a call by Carbex inviting applications for development of sepsis diagnostic. So in India also we are trying to push this. Besides that, ICMR has a treatment guideline and there is a complete chapter on management of sepsis. So these are some of the initiatives that ICMR has on improving the diagnosis, prevention, as well as treatment of sepsis.
Right. So early detection, diagnosis, and treatment. You've covered everything, ma'am. And that is very important. So my next question is to Dr. Yatin. What role can public awareness campaigns play in improving the early detection and management of sepsis? Dr. Yatin, please unmute yourself.
We have two senior panelists on this panel who represent the government of India. So I think they can play a very important role in spreading the word around. First of all, I think by 2050, sepsis is going to kill more patients worldwide than stroke, cancer, or heart attack put together. So it's a very big killer. Dr. Todi has already talked about certain numbers, 50 million patients worldwide getting affected by sepsis, and about mortality in severe sepsis is about 40-50% in India. So I think the mortality remains very high and the diagnosis is very late. Also, in a developing country like us, I think the implications of social implications and financial implications are tremendous. Antimicrobial resistance, I think we are the capital of antimicrobial resistance worldwide, and therefore we are going to have a serious problem because antibiotics are ineffective. So that is the seriousness of the problem which we have. How can we try to reduce the incidence? Well, I had a meeting a few years back with Southeast Asian country leaders regarding the misuse of antibiotics in public health. And India is not only the leader of consumption in poultry of antimicrobials, which significantly contributes to antimicrobial resistance. Not only that, the misuse of antimicrobials which we see, I mean, over-the-counter selling of the antimicrobials, chemists deciding of what antimicrobials to give, and by the time I and Dr. Todi are working in tertiary, and Dr. Ram is working in tertiary care hospitals, by the time the patient has come to us, he has already received multiple antimicrobials and he will be having antimicrobial resistance. So we have to shoot with the higher end antibiotics which are more expensive. The mortality is already increased by that time and they will get resistant infections, bacterial infections by the time they come to us. So I think public health awareness, that means the public must realize that diagnosis of sepsis should be done early. Local chemist is not the one who's going to diagnose it. I think they need to go to a doctor as soon as the infection doesn't come under control. Antimicrobial should be given by doctors, and the local GP also must realize, don't shoot the patient with 3-4 antibiotics and steroids in order to make the patient feel better. So I think the Indian Medical Association should play a better role in this to increase the awareness about misuse of antimicrobials, when to refer the patient, how quickly to diagnose sepsis, and so on and so forth. I think also public awareness, as I said, if you look at the public media, the TV, Every day, any TV channel you put on, the health care channel or whatever program is there is on heart disease, is on cancer, is on strokes. There is nothing on sepsis. I think we need to increase this awareness. Also, the government should put all the ministries together. I think the fertilizer and the health ministry and the ICMR should all come together to put a stop to use of antimicrobials for poultry farming. I think they should stop doing it. Also, we need to improve our public health concept. I think a water supply is not good. Public and the sewage system is almost non-existent. Drainage system of rainwater is almost gone. So leptospirosis increases during this period. I think we have really falling apart. The urban public health is really falling apart. I think these things need to be taken care of. Prevention is the best cure, and that is what we need to do. Improve our water supply, improve our sewage, improve our drainage system. In Delhi, they found resistant bugs in the water which was being supplied in the tap waters. I think in Okla area they found, I think this is dangerous. Was the patients who were completely antibiotic naive, that means they had never received an antibiotic, can get infected with this antimicrobial resistance. Your therapy will be incorrect when the patient comes to you, and the mortality morbidity would be higher. So I think public health plays a very important role. Indian government is already spending a little more money than what it used to be in healthcare as a percentage of GDP before the COVID came in. It is increasing, but I think they need to spend some more money and some more time in improving these things.
Right. Right, sir. So my next question is to Dr. Ramasubramanian. How does procalcitonin differ from other biomarkers used in sepsis management?
Yeah, as we have been discussing, it is very important to prevent sepsis, but also as important to diagnose sepsis early so that we treat patients appropriately. Now, in the West, sepsis is reasonably straightforward. When somebody comes to you with fever and probably borderline blood pressure, a little confused, tachycardic, you think it is sepsis, and 9 out of 10 times you are right in suspecting either a gram-positive infection or a gram-negative infection. But in India, things are a little different. Sepsis, when the person comes to you with fever, tachycardia, tachypnea, confused, it doesn't always mean that it is a sepsis because of a bacterial infection. It could be malaria, it could be viral infections like dengue, it could be leptospirosis, it could be scrub typhus, it could be bacterial sepsis. In other words, you are facing a host of microorganisms or infections. I mean, leave aside the non-infectious causes of fever and tachycardia and tachypnea, we are dealing with a host of conditions, for all of which you may not require antibiotics. So it becomes very difficult to diagnose sepsis in a person with fever when they come to a casualty department in a tropical country like India. So which means your biomarkers should be reasonably specific in identifying sepsis of a bacterial etiology. So far, we have been relying on high white cell count, a high erythrocyte sedimentation rate, a high CRP, all of which have their uses, but it is very, very limited. Now, procalcitonin is useful because it has been shown to be quite specific in most situations. I repeat, quite specific in most situations in identifying bacterial infection, which is where the role of early antibiotics or the appropriate early antibiotics makes a difference in the outcomes. So procalcitonin in that way is superior to the currently available biomarkers. But having said that, let me make it very clear. At the end of the day, it is the clinical judgment of the clinician which trumps all this. In other words, even if your procalcitonin is low, the clinician may feel that if it is sepsis, you still need to use antibiotics. So this is a very important caveat. Among all the biomarkers we have, procalcitonin is probably the best currently available, especially if it is used in serial measurements to determine the occurrence of sepsis. More importantly, serially looking at it to de-escalate, like Dr. Todi said. But in the current armamentarium, in the management of sepsis, I would say procalcitonin has a very strong role to play in identifying sepsis of bacterial etiology.
All right. So my next question is to Dr. Subhash. What future research directions do you believe will be most impactful in advancing our understanding and management of sepsis?
Sepsis is a syndrome, and at the present moment, we have a sepsis management guideline which is kind of generalized. So I think the future research would be on how to do individualized sepsis management, how to identify subset of sepsis patient who may benefit from certain particular drugs. For example, there have been sepsis subphenotypes, alpha, beta, gamma, delta phenotypes. There are hypoinflammatory type of sepsis, there are hyperinflammatory type of sepsis. Which sepsis patients are going to benefit from steroids, which might be harmed with steroids? I think these are the certain areas of future research in sepsis is to identifying or individualizing patients with sepsis. In our country, I think with the tropical infection, sepsis is an infection with organ dysfunction. That infection could be bacterial, viral, parasitic, or anything. So, if we get a septic patient, especially with tropical infections, that is where we kind of are separate from a bacterial sepsis. And there are a lot of confusion in tropical infection leading to sepsis and septic shock. Where do we stand? Do we give steroids? Do we don't give steroids? What should be our fluid resuscitation strategies, and so on and so forth? So I think a tropical infection leading to sepsis will be a very important research topic for the future. Over to you.
Right. So, personalized treatment, that's what you're laying emphasis on. Correct. So, my next question is to Dr. Madan. How do current national health policies address the challenges of sepsis management in India, particularly in resource limited settings? Please unmute yourself, Dr. Madan.
Okay, sorry,
Unmute
sorry,
yourself.
sorry again.
No problem.
Okay, no problem. As I mentioned that we do have a national infection control guidelines so as to reduce the hospital-acquired infections. But the other public health problems which we are having is the maternal and the neonatal sepsis. So you have seen that the policies in 2002 and 2017, they have focused more or less on how to reduce how to target the neonatal and the maternal health. We have seen that most of the policies have revolved around that. And as a result, you have seen the reduction in the maternal mortality rate and the neonatal mortality. So there are many initiatives which have been taken. The Janani Suraksha Yojana. So previously, the infection was a problem. So we tried an initiative called TBA training so that the safe delivery can happen. The neonatal tetanus and the neonatal septicemia can be avoided with the just by intervention of the cord cutting intervention in a asepsis condition. That was tried and that has yielded result. That has given confidence and new policy shift has happened in which we focused on bringing all the women to the institutions for delivery. Now I'm happy to report that majority of the states they have picked up this initiative and most of the deliveries are now happening in the institution through a skilled birth attendant. As a result, what has happened previously, maternal sepsis was one of the major cause for, apart from the this hemorrhage and other factors. Sepsis was also one of the leading cause for maternal death. It has reduced because of this policy intervention. For improving the standards in the delivery of the woman, as I mentioned, that other initiatives are election certification is there. It is labor-owned quality standard, so that hygiene and other practices are maintained in the labor. Similarly, for resuscitating the newborns, how to reduce the infection in the neonatal wards and other things. If a neonatal sepsis is there, one of the commonest cause, how to handle that? So we come up with sick neonatal units as well as neonatal ICUs and other things have also been come up. So similarly for the ICUs, as I mentioned, that IPHS based on the criteria how the zoning and other things can happen so that the sepsis condition. So policies are in place. That means in 2002 also we talked about about the hospital infection, the maternal and the neonatal issues, because all of the public health was previously directed towards that. But simultaneously, from 2006 onwards, there has been a shift. Apart from providing services and reducing the infection, now we are focusing on the health events. The health events have been focused, and all the infections has been mentioned that the the, the futuristic research would be the orthoborne infections or other infections would be there. But to keep a track on the infection, we do have a program which is known as a integrated disease surveillance program. Currently, we are monitoring the right from the occurrence of the disease to containment of the disease that is there. That thus treat and track is a part and parcel of this integrated disease surveillance program. So these are all the things in place. Now, with the NQAS, the NABH, and this IPH standards, you'll see that the hospitals as a place for providing care, they're also being taken care for this. Besides that, the antimicrobial stewardship program is there. So we are trying to create stewards in handling that. Besides that, apart from the hospital acquired infection and the antimicrobial resistance, the government has come up with a One Health program so that to handle the AMR in not in the human being but also in the animals and the other areas. One of the other major uh, area of concern, which can lead to antimicrobial resistance, is the environmental pollution by the manufacturing, the pharmaceutical manufacturing. That's an all area where a lot of focus is now there, so that whatever pharmaceutical effluent they are discharged, they are also being made antibiotic residual free, so that they don't pollute the environment. So environmental surveillance is also in place as a part and parcel of the policy decision. That means the sewage waters are also been now under surveillance for monitoring whether the antibiotic residuals are there, and if the residuals are there, whether it is resulting in any antimicrobial resistance. So, in nutshell, overall, we are moving in that direction where policies are in place. Only thing is how to make people aware about these policies and capacitate the people so that they implement all the things whatever is being agreed in letter and spirit. But nevertheless, the situation is not grim. The indicators are pointing that we are declining, but side by side, the antibiotic resistance is also increasing. It's a matter of concern. And with the limiting armament of this antibiotics, now we will definitely run out of antibiotics. We have to see that how we do that. Lot of efforts are also being. We are trying to see that how quickly we can detect the antibiotic sensitivity for any infection. So a lot of work is going on to develop and standardize kits so that we can detect which antibiotic is to be given in which infection, so that the decision happens fast. Right now, for doing the antibiotic sensitivity, it takes time, at least minimum 72 hours or 48 hours, not before that. Till the time the patient has to be put on antibiotics, uh, and you have seen what happens. That he's loaded with many antibiotics, and we don't know. That till the time the antibiotic sensitivity report comes, he has already received many of the antibiotics. So to just summarize your question, that means we do have policies in place. They have been implemented. We are working towards building capacities of the people and trying to have stewardship program so that we move in the right direction, the right path. Side by side, we are trying to address the issue of the diagnostics, how to quickly um, diagnose the sensitivity of that organism towards antibiotics so that he is put on the correct antibiotic so that the antibiotic resistance problem is also being taken care. Environmental surveillance is in place, the IDSP program is in place. So all the things are falling in place, and one and program has also come in. And ICMR is a nodal agency for this One Health program. Also, they have come up with the One Health Institute in Nagpur. So that means they are also taking a lead in bringing all the players together and address this critical issue. I stop here. Thank you.
Right. So, rightly said that AMR is a major global concern and we have to address it. So, my next question is to Dr. Kamini. Can you share some of your recent research findings related to sepsis and its management? Please unmute yourself, Dr. Kamini.
So as I mentioned that the focus in ICMR is to improve the diagnosis of sepsis, and that is why our research is focused in that direction, and also whether this timely diagnosis can improve the management of sepsis. So talking about the research in this direction, as I mentioned previously, we have developed a target product profile for sepsis diagnostics. We also evaluated one of the diagnostics which was indigenously developed in India uh, for sepsis, and this would actually capture the sepsis biomarkers from saliva samples. This was meant for the neonatal to diagnose the neonatal sepsis. Unfortunately, the results for this particular evaluation have not been very promising, and we don't see that it can make a major difference in improving or diagnosis of neonatal sepsis. So many such products or development of such diagnostics is actually being currently being funded by ICMR, and which will become available in next couple of years, and they will be then evaluated further in the field. One thing which is very concerning here is that what are the biomarkers actually which are currently available or which can be tested for which can be used for early detection of sepsis in Indian patients. So far, the imagination has been limited to CRP, PCT, and IL-6. But there are many other biomarkers which are currently available, which are currently also being tested for improving early diagnosis of sepsis um, uh, globally. And those are some of the approaches we need to bring to India and test them how we can create more affordable diagnostics using those biomarkers. Regarding management of sepsis, I already mentioned that ICMR has a treatment guideline which has a complete chapter on management of sepsis, and there are other members on the panel who can apprise on that. Dr. Ramasubramanian is part of the ICMR treatment guidelines as well as the ICMR's antimicrobial stewardship program. We were also in the initial stages guided by Dr. Todi. Other than that, NCDC and ICMR are now working together towards revision of the existing guideline, and the forthcoming guideline will have more evidence-based guidance on how the sepsis should be treated in the country. But again, the same limitation that the data that we are going to use for building that evidence will come from ICMR and NCDC networks, and both the networks are actually operational only in the tertiary care hospitals. So going forward, we do have a lot of data on the diagnosis, the challenges in the diagnosis and the management in the tertiary care level, but we need to understand more what is happening in the district hospitals or smaller hospitals in corporate and the private sector as well, where there is not much knowledge which is available on what kind of antivirograms they have and what kind of antibiotic policies they should be following or are following. So I think we need more data on sepsis from the secondary care level. We already have enough data from the tertiary care.
All right. So data is very important. That helps us to make good decisions. So my next question is to Dr. Yatin. What are the economic implications of sepsis management, and how can healthcare systems balance cost and quality of care?
See, economic implications, as I said, once the patient has sepsis and is hospitalized and is in the intensive care unit, there is a substantial increase of the cost of healthcare. I mean, I can only talk about private institutions. And once the patient goes into the ICU, the cost implications are huge. And if the patient on top of that has antimicrobial resistance, which most of us have, patients coming to us have that, then the cost is tremendously much higher. There was, if you look at the early diagnosis of sepsis, procalcitonin, a few studies have shown that it significantly, I mean, 1.5 times the cost was less. 4 days of ICU stay was less once you diagnose the infection with the help of procalcitonin. So I think people talk about the cost of diagnosis or the cost of the procalcitonin substantially less than what we have the cost of the antimicrobials or the patient stay in the intensive care for much longer. On top of that, if the patient has organ dysfunction because of your inappropriate treatment, which has been shown that not only every hour of inappropriate antimicrobials increases the mortality, but also initially starting inappropriate antimicrobials and then switching on to appropriate antimicrobials, the mortality still remains high. So I think the cost implications of this patient, because at the moment we pay attention to only mortality or ICU and hospital length of stay, but these patients who have severe sepsis, or that term is no more used, sepsis or organ dysfunction, they take several months to recover normally to go back to work. There are psychological implications, neurocognitive dysfunction, the family suffers. So I think there is the hidden cost of the sepsis are tremendously high, underestimated. So I think we have to be particularly more careful because the resources are limited. 60% of our patients in the private hospitals do not have insurance, they pay from their own pocket. So these problems are not there in the Western world, where the public health or the insurance cover everything. So we don't have that advantage of that. So I think I think we need to take proactive measures to early diagnosis and preventing.
Right. So my next question is for Dr. Ramasubramanian. How can interdisciplinary collaboration enhance the research and the development of new biomarkers for sepsis?
As I said earlier, in tropical countries like India, the problem is in identifying sepsis because there can be not only the confusion between septic causes and non-infectious causes of similar presentation, but even among infections, there is a host of infections. Not all of them may require broad spectrum antibiotics. So you need to liaise with, the various stakeholders, which may include parasitologists, intensivists, infectious disease people. Not only this, you need to incorporate the role of antimicrobial stewardship. You need to incorporate the role of translational research in the lab from various non-medical personnel who may be more adept at coming out with various answers to the solutions. So you need to have a huge collaboration of doctors, non-doctors, basic researchers, non-medical, scientific people with whom you need to probably discuss the problems faced by a clinician in the emergency room or in the ICU to come up with solutions which may suit our needs. So basically, the research, especially in India, should be customized for the Indian doctors who are facing patients with suspected sepsis. The difference between the West and here is phenomenal. So we need to develop our own methodologies to approach, keeping in mind the problems which we face, including the problems of drug resistance and the problems of, economic constraints which we have in India.
Right, sir. So my next question is for Dr. Subhash. What are the challenges in differentiating sepsis from other infections or inflammatory conditions?
Sepsis is basically infection with organ dysfunction, and it has to be operationalized by SOFA score, which has its limitations. So I think a new definition where, because SOFA requires lab findings, which is not available to everybody. So I think in order to differentiate, first of all, infection with non-infectious conditions like like patient with trauma, pancreatitis, burns, post-operative. they can all look like sepsis, but they might not have an infection. They might have all the inflammatory response, but might not have an infection. And that is where a big problem lies. Nowadays, we sometimes diagnose infection because the patient is having an organ dysfunction, whereas organ dysfunction is not a part of infection definition. Infection has to be diagnosed separately and organ dysfunction separately, and if they are together, it is sepsis. But in many of the patients in ICU, if they develop organ dysfunction, we think they are infected. And that is where I think is the biggest problem. So we have to have a very separate identification who is infected and who has organ dysfunction. And that is where I think we require better tools to diagnose infection. Organ dysfunction diagnosis is relatively easier, but to diagnose infection, whether it is bacterial, viral, that is where the rapid diagnostics, the biomarkers, the host response, I think that is where it is going to play a very big role, how to diagnose infection. And then if the patient has an organ dysfunction, then they have a sepsis. And I think that is where, most of the time when we are sending samples for pathogen detection, it will detect a pathogen, but the same sample also have lot of host cells. It has neutrophils, it has monocytes. So there are lot of work being done now. Can we look at the host response to the bacteria or the virus or whatever there is in the sample? Does the host response implies that there is an infection? Is there a bacterial host response, viral host response, or no host response? That means that is not a pathogen, it's a colonizer. So I think that is where we are going to look for, is how to diagnose infection separately from organ dysfunction, to call it a sepsis. Over to you.
Right. So I think we should lay stress on training. So my next question is for Dr. Madan. What role does the government play in ensuring healthcare professionals at all levels are adequately trained in recognizing and managing sepsis?
Manisha ji, with very interesting question, very complex to answer,
Yeah.
because a lot of efforts are made, but still lot to be done. So that's my opening thing. How to answer this? Because if I talk about the capacity building programs, if you look at the structure which we are having, we have at the lowest outermost institution is your uh, arm center. That means Aishman Arogya Mandir in the government perspective, which is headed by uh, the CHO, Community Health Officer, who is from a nursing background. To assist him is the auxiliary nurse midwife. They are all being provided this skill-based structure. Is a CHO usually have the nursing training as well as 6 months intense training before he is inducted as a CHO in the and placed at the arm centers. The auxiliary nurse midwife, the ANMs whom we call, they undergo a skill-based training in which infection is an integral part of the training. And you look at the way this training has happened, and we don't encounter sepsis after vaccination. That means at the site of the injection of the vaccine, very seldomly some adverse reactions are reported in the form of sepsis. That means the capacity building of these people into the test. Second thing is the operating nurse midwife, the staff nurses, they have been trained for aseptic precautions during delivery, which is now, that's why we are now promoting the institutional deliveries, which are now quite happening. And the training for this is already only the IMNCI training and the other training, they speak volumes about the investment which we did on the training aspects. So the indicators are quite visible. The reduction in IMR, remember, that's a different story. But since you have asked about the question about the training, these trainings are going on, which is evident that how things are happening. For the medical officers, also some training is happening. We have to see that how the medical officer, we are trying to have the Shashak platform is there, where the online training modules are there for the aseptic precautions. Besides that, we do have some program, the TV program, the HIV/AIDS control program, and the HIV/AIDS control program has shown that how a universal precaution can result in reduction in the infection and infection control practices. So that program is there now, taking clue from all these programs. That means capacity building efforts are made, they are ongoing, and they are further strengthened with the use of the digital aids and other things. So these are all being done. The only thing is if the infection, the rates, the indicators, if they give us a comfort saying that yes, these are declining, then only we'll say that whatever we are investing now in the training, that is yielding results. So a structured program is there and we are working in that direction.
Right. So my concluding question is for Dr. Kamini, that what are the current gaps in sepsis research that need to be addressed to improve patient outcomes?
So, as I mentioned previously, there are three stages for containment of sepsis: the prevention, the diagnostics, as well as the management. I think we need to focus more on prevention and diagnosis. There is a lot of focus on treatment. We have different drug regimens, we have different guidelines to treat, but the prevention and the diagnosis of sepsis still remains very challenging. There has been a lot of research on microbiome of the sepsis patients, that are some patients more likely to acquire sepsis. So I think we need to do those kind of studies in India, that what is the composition of microbiome in the patients who progress to sepsis, and how we can really utilize that part in prevention of sepsis. The other very important is what are the environmental reservoir for drug-resistant infections through which the patients acquire these drug-resistant pathogens in the community as well as in the hospitals, and how our wash, hygiene, and the infection prevention and control practices can actually limit our the sources of infection in community as well as in the hospitals. Diagnostics, as I mentioned, is the most gray area, because the turnaround time for available diagnostics is very high, and many a times the patients are very sick, so it is not possible to utilize the output of those diagnostics really for improving the treatment or for the patient benefit. There are different biomarkers which are currently being studied. There is PTX3, there is calprotectin, there is presepsin. There is also now strategy to utilize the omics approach. Can we improve the diagnosis of sepsis by using circulating DNA, by adding next generation sequencing, and how can we reduce the turnaround time for these patients? So all these approaches, and of course, I think we should be for the available treatment regimens. We need more studies. What are most effective drugs, as well as the combination of the treatment strategies for the drug-resistant infections, which actually are causing sepsis in our country. So we need a more multidisciplinary and a more comprehensive approach towards containment or reduction of sepsis in our country.
Right. So, as we conclude today's section, let's remember that critical importance of timely action in preventing and managing sepsis. And with awareness, early intervention, and infection prevention, we can save lives and improve patient outcomes. Thank you all for your participation and commitment for this vital issue. Thank you.
Thank you.